So, hi everyone. Thank you all for joining. This is a webinar from the Global Observatory of Long-Term Care. Specifically, this webinar is organized by the Economics in Long-Term Care Interest Group. Adelina Comas-Herrera is the director of the observatory, and my name is Naz, and I work as a research coordinator at the GOLTC. And I will be doing a quick introduction of the observatory today. So what is the Global Observatory of Long-Term Care? The GOLTC is a platform for cross-national learning designed to improve and strengthen care systems globally. Our goal is to identify shared key challenges and showcase how different countries and communities are addressing them. This is an open space for anyone interested in long-term care, including policymakers, industry members, advocates, care professionals, and academics to share knowledge and foster collaboration. So how do we make this happen? The GOLTC thrives on the willingness of its members to share knowledge and experience. We share publications, build country profiles, and host blogs and guides on key topics and methods. At the heart of the GOLTC are our interest groups. These groups organize webinars, share resources, and collaborate on issues that matter most to them. And we have a large variety of interest groups that all members are encouraged to join, steer, or consider making their own. And this is a space for learning, connecting, and driving change together. So looking ahead, we have a collaborative webinar from the Data Science and Qualitative Research interest groups on December 10th, and I'll share a link in the chat so you can explore what's next. But for now, I will pass it over to the Economics and Long-Term Care Special Interest Group to begin the webinar, and don't worry, I will share the link for how to join in the chat as well.
Okay, thank you, Naz, for the introduction, and hi everyone. Thanks for joining us from around the world, I can say. I had a quick look at the participants list, and I'm excited to see you all here. So I'm going to quickly introduce our interest group. I hope everyone can see my slides now. If you can confirm, Naz.
Yes. We can see them.
Thank you, perfect. So the Economics of Long-Term Care Interest Group was formed in 2024 within the GOLTC. So our aim was to actually bring together the health and social care researchers, policymakers, and practitioners from around the world to discuss around the economic evaluation and financing approaches for the community-based long-term care, and also to measure the impact of long-term care policies on the population. So the interest group is focused on the social care and community-based interventions in response to the health and social care needs of the older population.
Lady?
Yes.
Just to jump in, I don't think it's in presenter mode for us, which is okay, but it's not changing the slides. So you might just need to take it out and then on the left-hand side, just manually click the slides.
Okay, yeah, because I put it on the presenter mode on my side. So let's just put it on the, okay, yeah, I think that's better. Yeah, thank you, Naz. So we use this interest group as a platform to bring those who are interested in this topic by having webinars, sharing the resources, and having the web page within the GOLTC website. Some of you may already been to our previous webinars last year around the economics of long-term care and home care teams. And for today, we are going to talk about evaluation of long-term care policies around the world with our colleagues David, Ludovico, and Delphine, which I'm going to introduce later. Within the interest group, we have a steering committee. So with my colleagues, Dr. Elizabeth Lemon from the University of Edinburgh, and Dr. Courtney Van Houten from the Duke University School of Medicine. Both Elizabeth and Courtney has interest in economics of aging care and also the unpaid care in particular. Then we have my colleague Cassandra Siemens, who is not with us unfortunately today because she has just started a new job, and so we couldn't have her here today. So Cassandra was working as a consultant in World Health Organization Regional Office for Europe, and she has extensive experience in long-term care policies and financing. And myself, I'm Sadiqa Jebeli. I'm a research fellow and a health economist within the Department of Applied Health Science, University of Birmingham, and I have also the same interest in the long-term care and especially economic evaluation and population level impacts. So for today's webinar, as you probably seen in the advert, we are going to discuss the LTC long-term care policy virtual special issue published in the Health Economics Journal, which was actually a result of a conference by Gateway to Global Aging Data Project. So we have two of the authors here and Dr. David Knapp with us to discuss this special issue. So we have Dr. David Knapp from the University of Southern California, who is a labor economist himself with extensive research experience and interest in long-term care, retirement, and aging policies, who is going to talk us through the special issue and which is around the long-term care policies around the world. And then our speakers, which I should thank for being here today with us and present the papers. Dr. Ludovico Carino, who is an associate professor of public economics at the University of Trieste, Italy, and also a visiting senior lecturer at King's College London, who is going to talk about the impact of public home-based care on the mental health and well-being of older people. And Dr. Delphine Roy from Paris School of Economics, who is going to present her paper on the strategic coding in the assessment of the long-care needs based on the evidence from France. So just few housekeeping notes. So the webinar just runs for another 50 minutes. And we will have 10 minutes at the end for the question and answers, which is going to be led with, by my colleagues, Courtney and Elizabeth at the end. And please feel free to use the chat box to post your questions and also raise your hand actually function in the Zoom to ask your question at the end. So thank you, everyone. Now I will hand it over to David to start the webinar, please. Thank you.
Thanks, Seti, for introducing all that. And we're really excited to be part of this working group. We really think we think a lot of the Global Observatory of Long-Term Care and are really excited about this opportunity to have more discussion around long-term care policies. My role here is to introduce the health economics special issue that the Gateway to Global Aging launched. My name's Dave Knapp. I'm an MPI on the Gateway to Global Aging data, and part of my role is helping lead our policy initiative. So I'm going to give a brief background on the Gateway and why we did this in the first place, and then I'll talk through this special issue. So the Gateway to Global Aging data, it supports research using the International Network of Health and Retirement Studies. Many of you may be familiar with some of those studies, including the English Longitudinal Study of Aging or the Survey of Health, Aging, and Retirement in Europe. But the Gateway as a whole covers over 40 countries in the International Network of Health and Retirement Studies. An important component of the work that the Gateway does is helping understand and contextualize how policies have evolved over the past 30 years in terms of how the international network, in terms of the period covered by the international network. And this change in policy is really a barrier to cross-national research that the Gateway, like the Global Observatory, is working to reduce. So starting in 2022, we began collecting information on the evolution of long-term care policies and promoting related research. As part of our long-term care policy effort, we collect policy and document it. We developed a framework of care needs and have developed narratives that match survey questions to the different elements of care needs. And then we map those needs to care needs assessments in individual countries and states within the US. And then we can we are developing tools that will allow users predict prospective eligibility for benefits, irregardless of whether or not people take them up. We have a policy explorer that captures current and historical policies across countries, including long-term care policies, as well as retirement and education policies. And the key dimensions to our policy explorer are policies, such as cash benefits and in-kind benefits. And we allow users to look across countries or states in the US and across time as well, so typically from 1992 to present. Things that we cover in our policy documents are policy changes, financing, we give an overview of the system, but also coverage, benefit, eligibility distinct from just call it coverage, so benefit eligibility distinct from coverage. The care needs assessments that are used across time and across countries, as well as limitations on benefits and user costs. And we try to provide users kind of the tables and formulas to determine eligibility for benefits and what type of benefits they would be eligible to receive. In our effort to promote long-term care research, in 2023, we posted an open call for papers on research evaluating long-term care policies. That conference was in November 2023, and that special issue was in August 2025. As in both cases, right, all of this research was supported by, with generous support from the U.S. National Institute on Aging. And so we have a summary plus links that I'll drop into the chat after I'm done. But essentially, all those papers are now open or available on the Health Economics website, and they're all open access. So you should be able to download them and access them without any type of gated permissions. Let me talk through some of the articles in the special issue. So one of the articles was on the demand for long-term care. It was by Julien Bergeau, Irene Ferrari, and Yi Gao. It identified a causal link between unexpected health shocks over a person's life and the long-term care decisions using panel survey data from the Health and Retirement Study in the US and the Survey of Health, Aging, and Retirement in Europe. They use an event study differences approach to examine how older adults' health shocks and the care needs that may stem from them affect their transitions into various care settings and influence their children's employment. So a very interesting and timely paper and a nice comparative analysis. Another set of articles in the special issue really focus on aspects and implications of informal caregivers and care at home. So in the European context, Joan Costelefant and Cristina Villaplana Prieto wrote a paper that investigated the cost of unpaid caregiving by friends and families. What was really nice about this paper, amongst many other things, was that the authors reviewed alternative methods for estimating the value of unpaid caregiving. And the authors end up using a well-being approach, which is a non-monetary approach to estimating the cost of care, and they use shared data. Their model produces an estimate of compensating surplus, which is the income equivalent transfer required to compensate for the net cost of caregiving. And they find that there's substantial variation within the European countries that they study in this compensating surplus for caregiving. And they discuss how some of these differences connect to long-term care systems. Another paper was in the US using the Health and Retirement Study, looking at the impact of caregiver type on care recipient health outcomes by Norma Coe and co-authors. The authors highlight how little is known about whether the type of caregiving impacts a care recipient's health outcomes. Conditioning on receiving care, the authors investigate three alternative forms of care receipt, including family care only, formal care only, or a combination of the two. Using a traditional IV approach, they actually find that combining both care types is strongly associated with better self-rated health, greater reported mobility, and lower depressive symptoms. But they find no difference when each of these things individually are changed on health outcomes. So formal care only or family care only. So a very important contribution in highlighting the interconnected relationship between these two types of care. Another two papers, one that we'll hear from today by Ludovico and another by Jennifer Aylshire and Maria Casanova, looked at the impact of care looked at the informal care impact on mental health outcomes. In the context of the Aylshire-Casanova paper, they focus on the mental health impact of spousal caregiving in the US using the Health and Retirement Study. And as Ludovico will discuss today, they focus on the impact of formal care on the mental health and well-being of care recipients using shared data. The last set of papers looked at a combination of topics really circling around long-term care policy, focusing on long-term care coverage, insurance, and economic payments and incentives. In China, the Han et al. Paper looked at the impact of long-term care insurance on the use of inpatient services. So some of you may be familiar, given our general interest in long-term care and long-term care insurance, but in China, long-term care insurance was initially introduced in an experimental setting in 15 cities in 2016, and was later expanded to 14 other cities, as well as independently adopted by some cities across China. This creates a nice natural experiment, and so the authors, using the China Health and Retirement Longitudinal Study, compare treated individuals, those who need care, with untreated individuals, such as those who without care needs in the treated cities, or those with care needs in untreated cities. They find, they find that long-term care insurance reduces hospital admissions and inpatient hospitalization costs. In France, Delphine, who will present today, looked at the role of strategic coding and care needs assessments and the consequences on who actually gets access to care. So another fascinating paper, really focused on kind of the importance of care needs assessments in determining care access. And so I'll leave it to her to describe her paper a bit more. And finally, another paper by Salas Ortiz and co-authors in England, using the English longitudinal study of aging, looked at mechanisms through which adult social care spending influence the quality of life, the quality of life for those with care needs. All of these papers are really interesting and use a variety of causal approaches. So I encourage you to take a look at them. And so in the chat, if I can find my Zoom bar here, I will drop the link to the special issue there. And I will also drop a link to a blog post that we did kind of covering both the conference as well as the special issue, in case you're interested in reading up a bit more on the details there, including some, I think you can actually view some of the policy roundtables that we had as part of that meeting. Anyway, it's a pleasure to be here today, and I'm looking forward to Ludovico's presentation as well as Delphine's. And thank you all for your attention, and we look forward to any questions you might have at the end.
Thank you, David. Great. So Ludovico, please. Yeah.
Sharing my screen. Please confirm you are all seeing this.
Perfect.
Perfect. Okay, my presentation is going to summarize a paper that we did with Mauricio Avendaño and Erika Reinhardt on the effect that receiving public home care has on the psychological well-being of older Europeans. The research question, therefore, is exactly this, in particular, the impact of publicly funded long-term care provided at home. The approach is going to be challenging the identification problem, which is the way in which we try to identify the causal mechanism that links a receipt of care to mental health. We will use data from SHARE linked to an original collection of contextual information on legislations that provide information on the eligibility rules through which Europeans can or cannot get access to public long-term care. And we will exploit this in an instrumental variable approach. And the main result will be that receiving care has a causal impact, a beneficial causal impact on psychological well-being, a reduction in depression and in feelings of loneliness. Now, I don't need to restate this in this context, of course, but I will just focus on the fact that with aging populations and the focus on long-term care, the relevance of long-term care policies in the future, there is a shift towards publicly funded home-based care from institutional care. And this shift, and anyway, the rationale behind it is that home-based care provided at the recipient's home, is expected to improve the outcomes of the person, improve the functioning and the quality of life, delay or prevent institutionalization, and reduce cost. These are the hypotheses, the aims, but there is limited evidence on this in the literature. We will focus on mental health. We will focus on depression as one of the main outcomes. We know this is a major cause of disability. It has a very important economic cost, very important negative spillovers on families and society. Is a very prevalent disorder and important across among older people in Europe, and linked also to other types of problems like physical and cognitive functioning. Now, what's the empirical evidence on the link between use of care, recipient of care, and psychological well-being? There are a few studies on this topic. There are studies on mortality and hospitalization, but less studies on mental health. The studies that have attempted to study the link have mixed results. And I here list relevant studies on this, and probably I'm missing some new studies, even though I'm trying to update myself, of course, on the literature. We have a study by Barney and June in 2016 that they find that receiving care improves the general mental health of people in France. Many studies use, for causal identification, macro level instrumental variables, for example, the expenditure in the area, and this is problematic, or at least it leaves open room for more precise instruments, perhaps at the individual level. And for those of you who are econometricians or public economists, you probably know how struggling it is to find proper instrumental variables for causal identifications. Now, what's the theory behind our research question? Actually, in economics, the models of utility, for example, assume a positive causal link between receiving care and utility through different channels. And there is a strong literature on this, but it's almost taken for granted that utility is a function of health, consumption, and leisure. If health worsens, utility loss occurs, and receiving care is something that improves health. Now, so the marginal productivity of care is assumed to be positive. Actually, I'm not going to spend time on this, but the economics and sociological literature, actually not the economics, sociological, gerontology literature, and many other disciplines actually point out that receiving formal care might be beneficial for psychological well-being, but it might also be detrimental, actually, for different reasons. Receiving care might increase people's capabilities. It might improve people's social integration and connections, but it can also make emerging, let's say, emphasize the lack of self-sufficiency of the person receiving care, and through this, essentially trigger an identity revaluation of the person that sees themselves as someone who is not able to actually live fully their lives. And we essentially try to study what's the net effect of receiving care against this framework. Empirically, this question is challenging because we cannot just compare the well-being, psychological well-being, of people receiving formal care and compare this to the psychological well-being of people who are not receiving formal care. We cannot do that because there are many endogeneity problems. For example, the fact that people who are sicker are more likely to receive formal care, and because they are sicker, they are also more likely to have a worse psychological well-being. So in this paper, we try to tackle this issue. The data we use is data from the Survey of Health, Aging, and Retirement in Europe. We use waves from 1 to 7 in this paper, which is already published. We focus on a sample of people aged 60 and older, and also restrict this sample to older people, let's say older people in the robustness sensitivity of this paper. We focus on 4 countries for empirical reasons that I'm going to outline later: Belgium, Germany, France, and Spain. Our measure of depression comes from the Euro-D variable, which is a clinically validated measure of depression, introduced by Prince and others in 1999. This is a continuous variable, sort of continuous variable. Actually, it comes from self-reported answers that people give to 12 questions in the SHARE survey. This variable comes also in a caseness version, so a binary indicator that captures clinical relevance of depression condition. We also use another externally validated measure of loneliness coming from the University of California, Los Angeles, so UCLA Loneliness Index. And also a more general measure of quality of life captured by the CASP index that evaluates people's self-reported feeling of control over their lives, autonomy in their life, pleasure in doing activities in their life, and the extent to which they feel self-realized. So in our sample, focusing on these 4 countries, this is a table of descriptive statistics. You can see in the Euro-D caseness row that around 30% of the sample is at risk of depression. So as a depression score which is above the clinical threshold, the minimum threshold. And in the overall sample, around 9% of people receive formal care. This varies widely across the countries that we evaluate. Now, what are the methods that we exploit to study our research question? As I said, we want to study the link between receiving home-based care and depressive symptoms. And this is problematic also because those who have more depressive symptoms could also receive more care because they might have other health difficulties, for example, and for many other reasons. So in this paper, we essentially take an instrumental variable approach. We want to find an exogenous reason for people to receive home-based care. And we believe that a good example of this, such an exogenous incentive, comes from the legislation that regulates access to care. So access in long-term care is based on a needs assessment in most countries, and if people, let's say, satisfy this needs assessment, they can receive some care. So we use this information as an exogenous incentive, let's say, for people to receive care. Eligibility for care. This is something that Gateway to Aging has studied extensively, as Dave has described. It varies widely across Europe. In words, it's simple. Every legislation says if you have problems, you will receive some care. But actually, when you then study the legislation, you see that the criteria to establishing whether someone is entitled or not to receive cash or in-kind support from the public vary greatly. And they typically are non-linear aggregation on functional and cognitive health limitations. And so we essentially conducted a review of legislations in Europe, and many of these legislations have been then also more carefully studied and published by the Gateway to Aging policy. And we have decided to focus on 4 countries that have clear-cut legislations where people are evaluated. We know how they are evaluated in the law, and we know that if they are eligible, they have the possibility of receiving long-term care, in kind or cash, but oriented to long-term care. So what we propose to do in this study is essentially to do a sort of a simulation exercise, and based on the information we have on people in SHARE, we simulate whether individuals in SHARE respondents would be eligible or not to the legislations in their own country. Therefore, they would be eligible to receive care. We can do this because in SHARE we have the information to try to simulate the eligibility rules. We have information on people's functional limitations, and we exploit this. And we argue that this instrument is informative because being eligible to receive care matters a lot on the probability of actually receiving care. And we also argue that this instrument is exogenous, meaning people cannot change the legislation. People have their own health criteria, and if they are subject to different legislations, they would have different outcomes in terms of different probability to receive care. And we try to prove this in the paper. I'm going quick just to go into the results. We estimate, therefore, an instrumental variable model. And the results of this model you find in column 4, the main results in this table. Now, the instrument is strong by the standard definition in this literature. And the column 4 shows you that people who receive any formal home care, compared to those who don't receive formal home care, have a lower depression score by 2.2 points out of 12. This is controlling for health outcomes of people. This is what we argue is a causal effect. So taking people with similar health conditions, similar other characteristics, but someone is eligible for care and someone is not eligible for care due to their specific combination of deficits, leads to this result. That compared to someone with similar health but not eligible for care, someone who is eligible for care and therefore receives help has a lower depression score by 2.2 points. And this is a meaningful effect according to the Cohen-D taxonomy. This is a large effect. We have estimated the same model on the caseness EuroD score, so the binary index at risk of depression or not, and we find that receiving formal home care reduces the risk of depression by 12.3 percentage points, and which is a relevant result because 30% of the sample is at risk of depression, as I have mentioned. One of the main mechanisms we think is at play here goes through loneliness. Receiving formal care reduces the risk of loneliness that people report by 5.5 percentage points, and the baseline in this sample is 12%. So 12% of the sample report being at risk of loneliness. This means that somehow receipt of formal care reduces the feeling of lack of companionship, reduces the feelings of being left out, and reduces the risk of feeling being isolated from others. We also have an effect on the quality of life measure. We find that receiving any formal home care, again, controlling for health, instrumented through the eligibility status to long-term care benefits, increases the feelings of control over someone's life. The general CASP score has a positive coefficient, but is not statistically significant. And in column 7, you see receiving formal home care leads to a higher probability of having a quality of life higher than the median score. We have run a lot of sensitivity analysis, and I'm happy to discuss this in the discussion of this paper, but I want to jump to the conclusions to the discussion. I think our results highlight, as others studies in the same special issue, that there needs to be a broader and more comprehensive cost-benefit analysis of long-term care. We show that, first of all, the shift towards home-based care may be justified with the fact that receiving home-based care improves outcome of people, which is absolutely not to be taken for granted. The effects are also pronounced, are large, and we know that essentially these effects could lead to broader spillovers. A care dividend, something we have discussed in a recent book with other WHO colleagues. Receiving long-term care provides benefits that go beyond the recipient. For example, the cost of depression that we might save with a reduction in the risk of depression, they are huge and might impact also the well-being of households. There are limitations with the study. We cannot estimate the effect of care intensity. We only estimate the effect of receiving care versus not receiving care. We need further research on the quality of institutional care, not just home care, and for sure, better research on the intergenerational effect. Essentially, what consequences does my result have on other generations? For example, the offsprings of these people. And I'm gonna stop here and lead the way to the next speaker, Delphine. Thank you.
Thanks, Ludovico. Delphine, please. Yeah.
Yes. So let me share my screen. Okay, here it is. Right, so first, thank you very much for giving me the opportunity to present this paper, and also my renewed thanks to the Gateway to Global Aging Data for having published it in the first place. So it's about strategic coding in the assessment of long-term care needs, evidence from France. And so why do we care about this? Is because there is extensive evidence that upcoding exists in healthcare literature, from the healthcare literature. And so what do we mean by upcoding? It's when a provider submits codes for more severe and expensive diagnoses that are actually observed in the patient in order to maximize their revenues. And so the question here is there such a phenomenon in the long-term care context? Which is important because the first question when you want to compensate for long-term care needs is to properly measure the needs. And so the question here is who should do the assessment? Should it be independent from the funding, or do we, on the contrary, want evaluators to internalize the budget constraints and not to just upcode the needs? Okay, so we have evidence from France on this because we have this particular setting in which the evaluators are different at home and in nursing homes, but we have data which is very comparable across settings. So I can compare the difference in these assessments across settings. And so the findings contribute to 3 strands of the literature. First, about upcoding. And I show that long-term care assessments also respond to the economic incentives of the institutions that performs them. Nursing homes ownership, also because I see differences in this strategic coding behavior from depending on the ownership of the nursing homes, but it goes the opposite way as from what we would expect, because public hospital-owned nursing homes seems to upcode patients the most and not privately owned nursing homes. And so to explain this, I link this result with the presence of more low-income, socially isolated, and psychiatrically patients with psychiatric conditions. So it might be considered not maybe upcoding, but side coding or corrective coding for these patients. And finally, it also says things about cost shifting, because at home, where the evaluator is also the one paying for the benefit, on the contrary, it seems that the local authorities are downcoding patients at the margin to shift some of the costs towards informal carers. So the context, I will not dwell into this. It's distinct. Long-term care is distinct from healthcare, and so as I said, once you have eligibility for long-term care, you can either get benefit at home or in a nursing home. But when you're in a nursing home, the funding goes directly to the nursing home, and you can just have 2 amounts, whereas it's more gradual at home. But the idea is that the evaluation grid looks like this. You have several ADLs, and you're rated A, B, or C, and your eligibility depends on the number of A, B, and C that you have. A being you can do things by yourself properly, spontaneously, completely, and regularly. And C, you can do neither of the adverbs. And then you build a score and get classified into a group. And the important threshold is between disability level 4 and 5. And if you're below 5, then you're eligible to the long-term care benefits. Okay. So in the rest of this presentation, DL will be disability level. Okay. And so, as I said, the important point here is that in the community, the local authority evaluates and pays. So they have this economic incentive to underrate disability, whereas in care homes, they can charge and get refunded a higher price for higher levels of disability. And it's the Social Security organizations that refunds them, so they have an incentive to overrate disability. And I compare these official administrative disability levels to a survey evaluation, which is the same across settings. So I'm comparing the differences to assess whether there is upcoding or side coding. So my data is this survey conducted in 2015-16 with roughly 2,000 long-term care benefit recipients at home and 3,000 in nursing homes, and that they are matched with admin data. And my baseline measurement of disability needs from the survey is built from the questionnaire. It's built from the same ADLs as the administrative evaluation grid. And I have to make an equivalent from the levels of difficulty to matched with the can or can't do of the official grid. So it's only an approximation, but the point is that it's measured the same way in both settings. So what does this give us? It shows that first the main result descriptively, but that will stay true with econometric analysis, is that in nursing homes, for any survey DL, so even conditional on the survey disability level, the administrative disability level is more severe on average in nursing homes. So as you can see on this graph, it's always below the orange line corresponding to institutions is always below the gray line. Okay. And also we can see a big bunching at the eligibility level. So here on the horizontal axis, you have the survey disability level. So 5 and 6, if you look at the 4, 5, and 6, 5 and 6 are those levels which are theoretically not eligible for the long-term care benefits. But if you look at the vertical axis, the administrative disability level, you can see that many patients are coded for, meaning they are eligible for the benefit, whereas from the survey data, they would not be eligible. So there seems to be some bunching at this eligibility threshold. But of course, the patients in nursing homes are different, and you could think that this result is driven by the fact that they are more disabled, even with the same survey disability level. So we need econometrics to help us make this more robust. And so what do? I do an order logit model in which my dependent variable is the administrative disability level, and I try to explain it by the survey disability level with many controls. Okay, first the survey disability level and an interaction with the institution dummy to see if the effect of the survey disability level is the same across settings. And then I include many control variables, such as whether the person responded herself to the survey, because we know there's a proxy effect. Then we add socio-demographic controls, whether the age group, whether the person lives in a couple, the education level, etc. Then I add some controls for social vulnerability and also diseases. And finally, I add nursing home ownership, as I said, and a local authority fixed effects. And so because it might not be enough, I also match people, respondents between community and nursing homes based on survey variables predicting nursing home entry. And it's because we have such a rich data set with many variables, we can think that we can see that the matching procedures works fairly well. And also but on the other hand, there is also local variation in the supply of nursing homes and in nursing home use. So there's also a common support. People with the same probability of going to a nursing home will sometimes go and sometimes not go due to local factors that ensure there is variation in this outcome. And so the results, I've put very few tables. I will refer you to the paper if you want to see all the tables. But the main result is that the institution's coefficients remain fairly stable and strongly significant when I add controls and with the matching procedures, which is consistent with the initial hypothesis that care homes and local authorities respond to their own each to their own economic incentives and code patients at the margin more severely in institution and less severely at home. The second result is that two categories of patients seem to be particularly upcoded, and one of them is the patients with cognitive impairments or who in the questionnaire were identified as having Alzheimer's disease. And this is very interesting because it's a point that is often made by people who criticize the official needs assessment grid, which is notoriously not good at measuring the needs coming from cognitive impairments or Alzheimer's disease. So it seems like these patients are more upcoded on other dimensions because these limitations are not well taken into account by the grid. At least it's the hypothesis I make. And also, as I said, public hospital-owned nursing homes seem specific, whereas private nonprofit, private for-profit, and public non-hospital-owned care homes do not differ. The hospital-based care homes appear to rate disability in a more severe manner, even more severely than other institutions compared to people at home. And the main difference between these hospital-owned facilities and the others is that their patients are significantly poorer. They more often come directly from hospital stays, and they also have more psychiatric conditions. So maybe, at least again, I'm hypothesizing. I do not have causal evidence for this, but my hypothesis is that these specificities of the population accommodated by public hospital-owned nursing homes are not taken into account in the funding scheme. They do not appear in the grid, in the needs assessment grid. And so these hospital-owned nursing homes, they kind of do some corrective coding. They upcode the other needs of patients in order to actually have the appropriate funding that matches the time these patients need. And so I'm getting to my conclusion is that so I find evidence of upcoding in nursing homes and or because I'm measuring the gap between two differences, it could also be that there is downcoding in the community, in people who live at home. But the gap is pretty big, and even though my method is only partially causal because it's based on matching, the gap is so large that it's difficult to not to believe that it's at least partly caused by their economic incentives because nursing homes want to maximize their funding, whereas local authorities are trying to minimize cost and maybe shift some of the cost towards informal carers. One big limitation of my comparison, which I need to point out, is that the official measurement tool measures what is actually done, whereas my survey measures what the person can do with or without difficulty. And so it's not the same in the way that, especially in nursing homes, there are people who could do things, but they don't do them anymore because of organizational factors, because of the way the nursing home is organized. People are, for example, put in a wheelchair to go faster, or because it's the routine in the nursing home, or for safety reasons, because the staff thinks it's safer to do things for them instead of letting them do it themselves and risk injury or something. So the care is actually provided, even though the person could do it themselves. So it's partly a criticism of my results, but it's also interesting because the care is actually provided. So the cost is actually incurred by the nursing home, even though it might not be completely necessary, depending on how you see things. But anyway, it questions the way nursing homes are organized and what you call the patient's needs. And final slide, the policy implications of all this. For something I didn't mention so far, but it seems that there's a link between cream skimming and upcoding because publicly owned hospital facilities cannot cream skim their patients at all. And so they have a higher proportion of disadvantaged patients. And so it seems that they could be side coding patients because they cannot cream skim patients, unlike privately owned facilities. And so I think all of this brings arguments in favor of independent disability assessment that would prevent such a strategic coding, and also from a more French perspective, reforming the assessment tool that we currently use and the funding of nursing homes so that cognitive impairments are better taken into account, and also psychiatric and social needs are better taken into account so that facilities are less incentivized to side code or upcode patients for these reasons. Thank you.
Thank you very much, Delphine. Great. Now I will hand over to Courtney, please, to open up the discussion section. And everyone, please feel free to post your questions in the chat box or raise your hand.
Yes, I'm going to speak for Elizabeth, and since she's elected me with a sore throat today, so I don't have a sore throat, so I will ask, what questions do people have of the attendees that we can ask Ludo, David, or Delphine? Okay, well, I'll kick it off. So since Delphine, you just spoke, I'll start with you. One question that both Elizabeth and I had is sort of thinking about where you're going to take this work next, since it's already published, but you have some really fascinating results. For example, thinking about the downcoding in the community, are you going to think about looking at patient outcomes or client outcomes in the future? Or, thinking about the other thing I thought about is you gave some suggestions on how to change the grid to better account for objective care needs. Are there other things that you would recommend?
Yes, thank you, Courtney. For the next step of this research, first I'm waiting for the next for the data for the next survey, which was conducted in 2022 and 23. First, I will try to replicate what I found in this survey based on the older data. So in the meantime, what we are working on is try to understand the local fixed effects. So comparing the local authorities and with putting together data on the financial situation of the département, the local authority, and see if there's a link between many characteristics of the département and whether some of them tend to be more generous than others, and trying to understand that. And so far, we haven't found any explanation for the local discrepancies. And what was your other question about?
Thinking about changes to the grid, if you could
oh, yes.
Wave your magic wand, what would you recommend changes be made?
Well, there's a lot of advocacy these days around the use of, the staff grid, or I mean, the general idea is that we've been doing things too Frenchly and not looking at what's being done internationally. So I think there's a lot of interest in other grids and trying to improve this the French system by taking a grid that's more internationally recognized.
That sounds good. It's no surprise that people try to compensate when the measures aren't, even though they're using objective criteria, that they're trying to account for things like, well, the cognitive impairment doesn't show up well. So I know this is really a struggle. So those kinds of things, I've definitely experienced that in the VA system of care. So I'm excited to see what happens next. Any questions from the crowd? Otherwise, I have a question for Ludovico as well. Okay, Ludovico, both Elizabeth and I were very interested in mechanisms. You mentioned at the beginning of your talk, things like there could be negative impacts of getting home care, things like reducing self-sufficiency directly, that might be explaining things. Could you talk a little bit about mechanisms that you could possibly test in your slide that's set up? What are some of the possible explanations besides just getting home care that explain your results, including thinking about, were you able to account for household structure? Thinking about this idea that your findings on depressive symptoms may be going through loneliness. It could be that household structure is really important to think about as affecting loneliness, etc.
See, what we think we are getting at with this study is just the net effect of receiving care. So we cannot rule out that there are compositional effects that might be also negative. And the net effect we think is positive. Now, for many of the channels on, for example, feeling of self-sufficiency, identity revaluation, so the perception that someone is losing autonomy, the fact that people have eroding skills, eroding competence, so some of this we couldn't test, like the identity revaluation. The share survey has some variables that try to capture people's feelings and the view of one's own life. To the extent that we use that, we don't find negative effects, let's say, or we find null effects. Okay, we don't find that care leads to negative effects, but I'm not that confident that the quality of the variables we have allow us to really empirically test the complexity of a theoretical framework. So on that, I think we just need to look for further data or come up with better measured complex, perhaps composite indicators for those aspects. For that matters, so in terms of compositional, yes, we actually took into account the household compositions. We selected we estimated our model alternatively on a sample of all the older people, regardless of whether they have children or not, regardless of whether the children are living with them or not. And then we have also estimated the analysis on a narrower sample with people who are not living. So a sample of older people having children, but these children don't live with the parent, just for econometric purposes. The results are consistent. And we think that this means that the formal care leads to a better feeling, reduced feeling of loneliness, controlling for household composition. So it's something that it might come with the sort of interaction with the household composition, which we didn't find evidence for, but it might also be some sort of a positive spillover that receiving formal care can generate. Now, what we don't know is how does receiving formal care change the behavior of the informal carers in terms of their quality of care, their perception towards care. We have some evidence that leads us to think that receiving more formal care leads to increases in informal care as well. So a sort of a complementary effect, but we are still stuck at a rather quantitative measure of care and not qualitative measure. So I would really like to explore the angle you suggested.
Okay, that sounds good in terms of pushing things forward. I think I'm going to draw your attention, Ludovico. Thank you for your response to a question in the chat from Anne. But I'd like to, in the 1 minute we have left, turn back to David, because one of the things you mentioned, Ludovico, was we really need to think about wider cost benefit of long-term care policies. I think both of your papers were a beautiful, made that point very beautifully, because they were so careful in looking at effects on care received and thought about some of the spillovers to informal caregivers. Dave, thinking about your resource that the Gateway to Global Aging has built over the last 4 years, can you think about, is there one thing you want to just mention to the attendees where you could try to get at kind of this wider cost benefit of long-term care policies in the US and also internationally based on the Policy Explorer you've collected?
So I think one of the things that'll be really helpful to researchers as they continue or consider doing research on costs and benefits of providing care, both for informal carers as well as formal carers by, say, public long-term care systems, is kind of the role of care needs assessments in determining who is eligible for care. And so something we put a lot of effort into is kind of tracking the different approaches for assessing those care needs. I know Delphine mentioned the AGRIGRID in France, but there's an algorithm in Germany, in some U.S. states, right? It's simply meeting certain threshold criteria for ADLs or other medical needs. In Korea and Japan, there's actually a very kind of neat decision tree framework that corresponds to, or that then feeds into a formula. And so these different approaches to care needs really kind of dictate who gets access to care and when they get access to care. And that's really important, I think, for researchers to consider, and hopefully will inspire some new research in the future.
Wonderful. Well, I think we are at the top of the hour. You all saw in the link how to contact us, and please do join us in the future. Or if you'd like to speak as a part of the seminar series, could you let us know? Anything else, Seti? I'll let you wrap it up officially.
Yeah, great, actually. Thanks, everyone, for joining and supporting us. And also thanks to the speakers for presentations. That was great. And looking forward to see you all in the next webinars. Yeah, good luck, everyone. Yeah, thank you.
Thank you.
Thanks, everyone.
Thank you all. Bye.
Bye. Take care.